Hello, and welcome to the Chest Journal podcast, where each month we host a discussion with the authors of important articles from the current issue of the journal, adding context and commentary to the challenges facing clinicians in the fields of pulmonary, critical care, and sleep medicine. To introduce today's topic, here's your host, Dr. Alice Gallo de Moraes.
Hello, everyone, and welcome to the Chest Journal podcast. I'm Alice Gallo, your host, and today I have the pleasure to talk to Dr. Albina Tyker and Dr. Kerri Johannson about their paper on the recovery rate from exertional desaturation is associated with disease progression and mortality risk in patients with fibrotic ILD. Dr. Tyker and Dr. Johannson, welcome.
Thank you. Thank you so much for having us.
Dr. Tyker, I'm going to start with you, and I would love if you could share with our listeners a little bit about yourself and what in your day-to-day work inspired you to do this particular research.
Sure. My name is Albina Tyker, and I'm currently an interstitial lung disease fellow at McMaster University's Firestone Institute. But when we started the study, I was actually an internal medicine resident at the University of Chicago. And one of the things I really noticed in clinic is that patients would come to us and ask us, I have this interstitial lung disease diagnosis. What happens next? And we didn't really have good prognostic tools to tell them. And so I was really interested in coming up with something better, and 6-minute walk test stood out as a possible tool because it's fairly inexpensive, it's accessible to everybody, and there's no radiation involved. So I thought that was excellent. But when we look at results from 6-minute walk tests, it's pretty clear that you can have two people who have very similar 6-minute walk test results in terms of walk distance or nadir oxygen saturation, and actually clinically, they have very different outcomes. And so it was actually Kerri who came up with the idea to use desaturation recovery after exertion.
I love that. Dr. Kerri Johannson, would you mind introducing yourself to our listeners and also tell us what inspired you?
Sure. So I'm Kerri Johannson. I'm a pulmonary physician and associate professor in the Department of Medicine and the Snyder Institute for Chronic Diseases at the University of Calgary in Calgary, Canada. And I'm an interstitial lung disease specialist and clinician scientist. And I've been seeing patients with ILD since I started as faculty for the last 10, 11 years. And one of the things I noticed in clinic was that patients would come in and they'd say, Doc, my oxygen drops when I exert myself, but it bounces right back up. Yeah. And then as they started to get sicker, like a year or two later, they'd come in and be like, Doc, it's dropping and it's taking a lot longer to recover. And I was like, I heard it over and over. And this is where I come up with a lot of my research ideas, is just listening to patients in clinic. And I'm like, multiple people have said this, and it clearly corresponds, clinically with you getting worse. How could we study this as a potential marker of disease severity, disease progression? So I had this kind of idea brewing. And this is one of these wonderful organic collaborations. So my colleague at the University of Chicago, Dr. Deji Adegunsoye, we have collaborated on quite a few projects, and he introduced me to Albina, who was working in Chicago doing training. And, we set up a Zoom meeting and said, I've got this idea. And that's how we ended up doing it at the two centers, the University of Chicago and the University of Calgary. It's sort of one of these nice scenarios where you've got a colleague and a friend, and then find a mutual early career researcher to drive a project forward. So he's the co-senior author on this paper, and we had a really nice team to do this study.
That's the best. I love that.
Yeah.
So let's talk a little bit about the background of your study. Albina, would you like to start?
Sure. So when we first conceptualized the project, we looked into the literature to see what data was available in terms of desaturation recovery after 6-minute walk test, and really not a lot had been done. There were a couple of studies in the acute setting looking at hypoxia, which showed a really clear signal with poor outcomes. There was a couple of studies looking at desaturation product, which was taking several measures together. And there were a number of studies looking at heart rate recovery after 6-minute walk test in the cardiology literature. And those were promising as well in terms of providing prognostic information. But really, nobody had ever looked at recovery of oxygen saturation after 6-minute walk test in patients with stable chronic disease. And I think really importantly, no one had really looked at this in patients who were on oxygen. All of the studies that we came across either excluded patients on oxygen or they really didn't make any adjustments for those patients. So those patients were compared head to head with patients who weren't on oxygen. And to us, it was really clear that, first of all, a lot of patients with ILD require oxygen. And so the test should be done on oxygen. And also that it was really important to treat those patients differently. And so that's how we came up with the idea for the recovery index, which would take several pieces of information from the 6-minute walk test and combine them to give us hopefully a clearer picture in a disease that physiologically is complex.
Oh, yeah. I love that. Kerri, anything else to add?
No, I think the 6-minute walk test, I think about the 6-minute walk test probably too much. And I think, why do we do this? And it still ends up being an endpoint in clinical trials, not in too many clinical trials. There's so much heterogeneity in how far somebody walks and how long your legs are, what pants you're wearing, what shoes you're wearing. We do them all the time. And I'm like, I always think of this movie like, there's something about Mary. Why don't we do a 3-minute walk test?
Oh, yeah.
Why not 5-minute abs, why 6? And so I'm always like, why do we do this? And what other information can be gleaned from this? There's got to be more to this that is representing physiology. So I think it was just a handy metric. And I know there's been a lot of initiatives doing sort of sit to stand measures or doing home step counts and sort of trying to capture this function. We talk about an interstitial lung disease, how patients feel, function, and survive. And this seems to capture sort of the function part of it. So we're like, what else can we glean from this function component?
Yeah, and I think any pulmonologist who sees ILD patients thinks about the 6-minute walk a lot. You're not alone.
Yeah. And then what we found, we'll get into this, but what we found in the study is that we do them differently, like different centers apply them in different patient populations.
Yes. And one thing that always that always came to my mind when I'm seeing my patients, like, okay, but what if today your 6-minute walk was the first thing you did, and then last time you were here, it was like the 5th thing you did during the day? I think even patient to patient is like variation too.
Totally.
So let's then get to how you decided to study this correlation.
The way that we set up the study, we really tried to keep in mind that, patients are already having a long clinic visit, and so we don't want to add too much of a burden. We worked really closely with respiratory therapists to set up a protocol that would be convenient for everybody, but still capture the data that we wanted. And what we ended up doing is measuring the oxygen saturation during and then after the 6-minute walk test. And we recorded it in 15-second intervals from the end of the 6-minute walk test for a total of 180 seconds, which is 3 minutes. Yeah. And so the patients would get their oxygen saturation measured at the beginning, do a very standard 6-minute walk test. We'd measure it for the 3 minutes, and then that would be the end. And then afterwards, we went into their chart and obtained some of their clinical information and followed them for outcomes.
In that, you were looking into like seeing their desaturation and recovery. Like that's why you measured it at such frequent intervals.
Exactly. We wanted to see the lowest level they hit after the test and then how long it took them to come back to within 3% of their baseline level. So the number that we measured right before they started the test.
Okay.
So I kind of picture it like almost like an area under the curve, but inverse. They're dropping down, and then there's like this sort of like, submersive period of time from which then they kind of come and recover back. And what is representative with that, sort of area that's in that curve of recovery time.
Yeah. I love that. And then tell us, Albina, tell us a little bit more about the RI calculation then. How was that done in terms of like how are patients matched to their 6-minute walk and their desaturation?
Yeah, as Kerri mentioned, we're really trying to capture that whole experience of coming down and back up. So it wasn't really enough to see how low they went. We wanted to know how long it took for them to come back up. So the way that we designed the calculation is we measured their baseline saturation and then their saturation right at the end. We subtracted them out. So the end 6-minute walk test minus the baseline. For people who are on oxygen, we actually added an oxygen modifier to the numerator in flow liters per minute. And then we divided that by the inverse of the recovery time. So 181 seconds minus the recovery time, so that the higher the recovery index was, the longer it took them to return back to their baseline.
I love that. For our listeners, if you do have the manuscript in front of you, is figure 1. So with that, let's talk a little bit about what you found. Albina, want to start?
Yeah, I would say the highlight of our findings, first of all, we saw that the recovery index was associated with some baseline measures, including baseline lung function. So people who had higher recovery index, they also had lower FVC, and in some groups, lower DLCO. However, I think what was really interesting is that we looked at 2 outcomes, which was transplant-free survival and a composite outcome of transplant-free survival and 10% decline in FVC. And we actually found that people who had an elevated recovery index above a certain threshold actually had worse outcomes. So in our composite group and in our Chicago group, people with an elevated recovery index had decreased transplant-free survival and also had a higher risk of meeting that composite endpoint. What I will say is the way that we determined the threshold is somewhat specific to our population. So the threshold that we used, which was 3.97, I don't think can be generalized to everybody. It requires validation, but it gives us some idea that there is a threshold that can be used to provide more prognostic information for patients.
Kerri, anything to add?
Yeah, and I wanted to, just give a big shout out here. Albina devised this recovery index calculation, and there isn't really one in the literature to base it on. This is sort of an invented. It's informed. It's informed based on what we know of the walk and what has been previously published, and then the incorporation of the oxygen metric. And so, while it is sort of an in quotes invented metric, I think what's striking about it is that it works. So that sort of, it doesn't, I don't know if I can quite use the word validated, but it sort of justifies it. I would say that the fact that it identifies sicker patients and was able to identify worse outcomes sort of intrinsically justifies this calculation that seemed to have found the higher risk patients and this association with the predictor variable and the outcomes of interest. So yeah, it was really amazing. We went through like a few different versions of it until landing on this one, and I'm sure it could be optimized or changed in some way, but it certainly seemed to associate robustly and consistently. And one of the other things that we noticed was that the 2 cohorts are quite different. So it's interesting to see how different ILD centers have different patient populations. And our patient population in Calgary was more males, more Caucasian, was less sick, and compared to the Chicago cohort, sort of higher lung function. And interestingly, so in where I work in the province of Alberta, we cannot prescribe oxygen until people drop below 80% on a 6-minute walk test.
Oh, wow.
It's unreal. I've been fighting this for over a decade, and it's like, and so we don't. And we don't walk people in clinic when they're on oxygen. And, we'll do informal sort of, is this high enough type of thing. But the protocol in Chicago is quite different, where you'll get that as part of your routine clinical care, even if you're on oxygen. So it's interesting to sort of take into account the differing patient populations that we're seeing in clinic, the different access to oxygen, just to see, like, we didn't have any of our patients on supplemental oxygen because they don't do walk once they're on exertional oxygen, but in Chicago, many of almost half of them were. So difference.
One thing that did catch my attention in that specific, and for the listeners who have the manuscript, we're talking about a little bit about table 1 now, One thing that did catch my attention was the difference actually of ILD types. As you were saying, like more IPF in the Calgary cohort and more CTD ILD in the Chicago cohort. That caught my attention a little bit. And I always thought that it would be more tobacco use ever in the Chicago cohort when I started reading than the Calgary cohort. I don't know why I thought that, but.
Yeah, and interestingly, our ILD program here does not include sarcoidosis either. We've got a separate sarcoid program, and we'll have a few patients with it, but we've got a different sarcoid clinic here. So yeah, it's interesting the referral types and how different.
Yeah.
That's really important when we, this as an example of thinking of all different research, I think specifically within ILD, when we're describing single center cohorts, how different that might be from the patients that you see. So we hope, one of the strengths of this study, while the cohorts are different, we acknowledge that it's prospective, 2 centers, there was a prospective plan, and all you can do is say like, these are the differences, and it's what they are.
Oh, but it did catch my attention, and I thought it was also fascinating to learn. It was something extra that I learned by reading your study. Anything else on the results that you think it's important to highlight? Any of you?
I think one of the things that struck me was that patients in Chicago who are on supplemental oxygen still had desaturation greater than 10% on a walk test. So that was sort of a bit of, I think there's a lot of work I think that we need to do to appropriately titrate. I would imagine it's kind of like, if you've got asthma shouldn't be bothering your day-to-day life. If you're hypoxemic with interstitial lung disease and you've got oxygen, you shouldn't be desaturating when you're walking on flat ground for 6 minutes. But I think this sort of, how do we optimally titrate it? I think that was a noticeable finding for me.
Yeah. Albina, how about you?
I agree with everything Kerri said. I think those are really the most interesting findings. To your point about CTD, I wonder if part of it is because University of Chicago is such a huge quaternary referral center that we're capturing some of these more complex patients, whereas some of the IPF patients might be treated in the community. And so I wonder if that might be contributing to the differences in our patient population. Otherwise, in terms of results, I was really interested to see how the patients with oxygen compared to the patients without oxygen, and that the recovery index was still applicable to them.
Yeah.
The other thing that I think is worth saying is there were a couple patients in the Calgary cohort that were outliers in that they never recovered back to their baseline. And so they did have a very elevated recovery index. And, it speaks to probably some sort of characteristics in the Calgary cohort. I'm not sure if it's elevation or the fact that, people are quite hypoxic before they're given oxygen, but there's something physiologically different there. And so it's interesting to look at this subpopulation.
We are at 1,000 meters here, and I think it actually really, does impact things sort of similar to Denver or many places around the world, but I'm sure that has an impact. And I guess the other thing we couldn't really account for in the study, which I think is fine, it can be along sort of the causal pathway, but is pulmonary hypertension.
Yeah.
Whether that is the explanation for this in some patients, or really getting, but I think that's an area for future research, and whether it's present or not, it's still a manifestation of disease progression. You're assuming sort of group 3 pH in these patients.
Yeah. And has the practice where you are working already changed, already incorporated the index?
Oh, no, maybe I should. I just had that time, but we should probably incorporate this into our... I think that actually, would be informative. I've not quite adapted it to practice yet. Again, I'm not sure I guess we could use our own data set and use the threshold for the Calgary group to do that.
And okay, let's have fun here. How would you recommend incorporating the index if our listeners want to be like, hey, I'm gonna start calculating this in my patients?
So ultimately, it should probably be replicated and tested a few times, within your own patient population. But if you wanted to use our threshold or, probably a reasonable starting point, it adds 3 minutes onto the 6-minute walk test of monitoring and a sort of additional readout and printout. But it is, pretty easy to calculate. Maybe we could make a little.
Yeah.
You can make an app.
Yeah.
If anybody's interested in app development, we could add this to like sort of MedCalc or whatever. And you could have it handy. I think the number, I think the number would be informative. I think one of the takeaways, I wanted to highlight is that when your patients say, it's taking me longer to recover when I exert myself, whether they're saying it and they're monitoring their SpO2 on our home finger probe, or they're just feeling it, don't ignore that symptom. It's a marker that something's wrong. And so I think it's worth investigating, like repeating imaging, making sure you're getting pulmonary function tests and looking to see, is this a highlight of disease progression? And then the other part is that patients desaturated, but they didn't necessarily need to be hypoxemic. So there's been a lot of work that's like, if patients drop below 88% on a walk test, that's associated with worse outcomes. That's been well established. And I think Kevin Flaherty had published a paper a few years ago that had shown that even if they desaturate but don't become hypoxemic, it's a poor prognostic factor. So, our RI, recovery index, was calculated for many patients who desaturated but didn't go below 88%. So if you're seeing a patient and, last year on their 6-minute walk test, they were rock solid between 96 and 98%. Now they're dropping to 90%. That's a marker that something's changed, as long as the probe is on properly, and to really, flag that as if maybe there was a drop in FVC or a drop in DLCO. Like, take that as seriously when thinking about disease worsening as you would for other measures.
Yeah. And again, as a clinician, I'm coming to this as a clinician. It like the formula that you share is very easy to incorporate into like your just seeing your patient and doing this. I think, like you both said, how much coordination with RT that you had and all of that. I think the coordination will probably be a little harder to have this implemented. But it would be wonderful, right, to have this data so you can do your next thing.
Yeah, and then potentially like as it's doing the 15-second readouts, it could be calculated from just incorporated into when they get back to their baseline.
Yeah.
Oh, this is a whole idea. Oh yeah.
Right? I love it. I love it. Was there anything in your findings when you were looking at your results that you're like, oh, did not expect this one? Albina, let's start with you.
Yeah, Kerri mentioned this a little bit, but I think the degree of desaturation we saw in patients really shocked me, because these are people who are living with the disease, and I can only imagine how life-limiting it must be. Patients were desaturating quite low, even below 80% in some circumstances. And one of the things I'm not sure we talked about is there was some data that came out, I think, a few years ago that mentioned that people actually desaturate more in their day-to-day life than is captured in the 6-minute walk test. So it's possible that these patients we're seeing, even the ones on oxygen, are actually desaturating even more than the low numbers we captured on 6-minute walk test. And it goes to Kerri's previous point that we really need to pay attention to these numbers and probably need to do a better job of supporting people and improving their exercise tolerance in their day-to-day life, because that is really important. Outcomes and data has shown that.
Yeah.
And Albina, I love that study from Jacobo Solares from the Barcelona group. It's a research letter published in Annals of ATS that did 6-minute walk tests and then did home oxygen monitoring on patients in their day-to-day life. And it just really highlighted that when we're doing these 6-minute walk tests in clinic, we think, oh, this is like, representative of your day-to-day life. It's not, and we don't know. We use it as like this sort of artificial marker or surrogate, but there's probably a lot going on in their daily activities that it's impacting their symptoms and function, and that what we're doing in clinic, may or may not be representative of that. So this whole concept of home or mobile monitoring of activity levels and oxygenation could really be informative to guide supplemental oxygen use.
Yeah, more more real life data, like, right? Even extending the 6-minute walk to calculate the recovery index might also give us a bigger window into their reality, right? Like that was one of my takeaway.
Yeah.
And sounds like we have a call out for an app developer to help us with putting the calculations to test, and also more people to use this clinically so we can have more robust data. So if you have 2 or 3 take-home points from what we talked in the last 20 minutes, what would it be? Albina, let's start with you.
I think one of the things that the study really enforces is it's important to capture multiple aspects of people's 6-minute walk test results in order to really capture their physiology and help you better predict their outcomes. So it's not enough to know how much they're desaturated. It's not enough to know just how much oxygen they're on, that you really do get a better idea of how people are doing by combining these factors. And again, the fact that there's so much heterogeneity, I think suggests that there's probably more going on with this disease from a purely physiological standpoint than just, destruction of parenchyma leading to, low oxygen levels. So there's probably something at the vascular level. There may be group 3 pulmonary hypertension, as Kerri mentioned, and really trying to tap into all of these parameters to get a holistic look at the patient, I think is kind of what this study is trying to do, but I think we really need to continue those efforts. So I think that's one takeaway. And the second takeaway, I think, is just that from a research perspective, it really looks like people who are on oxygen are not captured well in studies. And so I think we really need to do a better job of including that patient population and better understanding how that oxygen supplementation is impacting their oxygen levels and their activity levels. I don't think we have as good an understanding of that as we think we do. And so hopefully recovery index is a tool people could use for that.
Oh, I love that. How about you, Kerri?
Yeah, I think maybe I've got 2. And one, I think there's so much room for additional research, just as Albina had outlined, additional research into oxygen. This is a major part of people's lives. It impacts everything that they do. And it's, some of the most common questions I get in clinic are pertaining to people's oxygen, their titration, how they're supposed to use it, what they're supposed to do. And I think there's a huge opportunity to focus in that area to meet patients' needs. And then I guess my second point, for anybody who's, looking to get into clinical research or trying to come up with an idea, is my recommendation is to listen to patients in clinic, sort of make these observations. It's exactly, people tell you what matters to them. You can think on your day-to-day basis, why do we do this particular thing? And you're like, actually, there's no evidence for it. Maybe we could study that. Come up with a hypothesis, and then take the opportunities to collaborate, reach out to a colleague, meet an early career researcher, and see where a study can take you to address what hopefully is a clinically meaningful question. And then, build a wonderful team of people that you can collaborate with. I think they're just really great relationships that you can build by just reaching out to colleagues and, meeting somebody new. And I'm really pleased with how this whole study turned out from a nascent idea in clinic.
I love that. I love it. I love it. Thank you so much, both of you, for talking to me. This was wonderful. I learned so much, and I hope our listeners learned too. Today, I spoke to Dr. Albina Tyker and Dr. Kerri Johannson about their paper, Recovery Rate from Exertional Desaturation is Associated with Disease Progression and Mortality Risk in Patients with Fibrotic Interstitial Lung Disease. Listen to your patients for research ideas that matter to them. Make sure to remember that if they tell you that their oxygen is not recovering as much as it was when they come to see you in clinic, listen and take a look at the calculation for the recovery index, because it might be helpful in clinical practice, and I am sure we're going to hear about it in the future. I am Alice Gallo, your host for the Chest Journal podcast. Thank you so much for listening.